Yo, 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 yo. Hey, guys, welcome back to another awesome edition of the Best Practices Show podcast. Thanks for showing up. Thanks for listening. Thanks for being here. Really appreciate all you guys. I love this profession so much. I love it. Dentistry is an extremely noble profession. And there's a lot of good people out there. And that's my goal, is to find them and bring them to you and add some value to your life. And today is a great example. So my team found Dr. Alan Budenz from the University of Pacific, and he has some great thoughts on local anesthesia. And he asked the question, are your patients comfortably numb? You'll love this. There are some great tips and some great pearls in this one. So hope you enjoy it. We'll see you guys soon. Hey guys, welcome back to the Best Practices Show podcast. My name is Kirk Behrendt, and I get to do the fun stuff here of just finding great thinkers in dentistry and bringing some great information to you to improve your practice and your life. I love it. I'm just the CE junkie, and I love this whole industry. And so my team is always on the lookout for new thinkers, new people that bring just new thought processes to the table. And I have one of those people here today, Dr. Alan Budenz, right? Did I get that right? Is that right?
Oh, yeah.
Yeah. And today we're going to be talking about, are your patients comfortably numb, and some of the concepts in local anesthesia. So Alan, thanks for being on.
Yeah, pleasure to be here, Kirk. Thanks for inviting me.
All right. And you know what? I don't know if you and I have ever met actually face to face ever.
No, we haven't. But it's overdue, you know?
That's okay. I like what you're saying. So I like to start here, if that's okay. I love learning people's stories. I love hearing about how they got to. I want to know your story, and I want our listeners to hear your story. So who are you and where are you? And take us on that journey.
Well, okay, I'll keep it dental though. So I'm a general dentist, and as a general dentist, to me, local anesthesia, getting your patients comfortably numb is incredibly important. You can't do good quality dental work if the patient's feeling pain and fighting you. So you've got to have good control. So to me, two big things. Number one, I want to deliver local anesthesia as efficiently as possible, because I've never had a patient, beg me to give them more shots. It's like, hey, I always think of the movie, Little Shop of Horrors, with Steve Martin and Bill Murray. And Bill Murray's like, oh, yeah, doc, hurt me. It's like, no. That's not real people. Right. So we're not going there. So I want to be real efficient with local anesthesia. And in giving the shot, inherently, you don't want to cause the patient pain giving the shot either. So let me go back. I was trained as an anatomist before I went to dental school. So when they were teaching me local anesthesia in dental school, they're talking about, okay, you want to look here, you want to feel here, you want to line up this landmark and this angle and all this stuff, and you give your injection. And then you sit back and you wait to see if it worked. Mm-hmm. And it's like, really? I mean, it sort of sounded like a wing and a prayer to me. Right. Didn't seem all that, knowledgeable. It's like it was so uncertain. And so I figured, if I'm going to be doing this the rest of my life, because I want to be that painless dentist that people want to go to, So if I'm going to achieve that, I want to learn as much about local anesthesia as I can. Right. So that's what started me on the path of learning as much as I can. And I'm still learning. Yeah. Which is good.
That's awesome. You got to always be learning. So, and then, so you actually teach at the dental school, right?
Yeah, I teach at the University of Pacific in San Francisco.
Okay.
And I've been teaching human anatomy here since 1984, and local anesthesia and oral diagnosis, a whole bunch of other things. I'm a general dentist. I teach everything.
Yeah. And so when you're teaching these kids who are just they're sponges for this, where do you start? And then what do most of them probably get wrong right away? Because you can't just learn this being taught it. You got to figure it out along the way a little bit, right?
Yeah, for sure. Well, it's the practice makes perfect. We've heard that a few times before.
Right.
Um, so I think we're pretty traditional in how we start out. The students, they're taught anatomy and all these things. And in the anatomy course, we do a lot of clinical correlation. So as we're teaching anatomy of the oral cavity, we are talking about local anesthesia to some degree. But then they do have a local anesthesia course, and they again review the anatomy and the landmarks and discuss the techniques. And for the mandible, which is always the bigger problem to get successfully numb, we always start with a conventional inferior alveolar regional nerve block technique. And so in doing that, we walk them through, they palpate on each other, and we use Q-tips, line things up. But then once we've gone through those basics, then the students have that wonderful privilege of injecting each other. And of course, that creates all kinds of wonderful experiences and stories.
Yeah.
You can imagine.
I can only imagine.
Yeah. And I mean, well, we do have them inject into oranges and things like that, for some practice too. But it has a feel of inserting a needle into the cheek, but other than that, the orange doesn't respond like a human being does. So it's kind of,
Yeah.
We do these weird, funky things. We're starting to work with mannequins. There's some pretty advanced mannequins now that have a pretty good feel of what human tissue is like. And they actually have some electronic components that lets you know whether you hit the right spot or not, which is
very cool.
I wish human beings had that,
For sure. Yeah. So, and then when, this has come a long way too. So if I'm a young dentist listening, give us a little history lesson on the evolution of this. We always talk about technology, how fast technology has changed, but local anesthesia has changed quite a bit too in the last, I'd say 5 to 10 years. Don't you think?
Oh yeah, for sure. So, injectables have been around since the late 1800s. Started out where they were injecting cocaine. Unfortunately, that led to a lot of problems, as you can imagine, both with patients and practitioners.
For sure.
So they went away and they started using synthesized esters that were derivatives of cocaine. And then they moved to the amide anesthetics, but still with a conventional syringe delivery technique. But what we're seeing now is that we have computer-controlled injection devices that allow us to inject the anesthetic still with a needle, but with a less cumbersome-looking handle, so to speak, and at a pressure that's below the pain threshold for a patient, and also at a slow rate that is pretty painless for a patient.
Yeah.
But that's still with a needle. Now there's a fair amount of research going on. There was a product brought to market a little while ago called Covanase, which was a nasal spray, a local anesthesia spray that could be used for the anterior maxilla to anesthetize that area. And it was an effective product. Problem was, I think it was a little overly priced on the market, and I don't think that they are in business anymore. At least I haven't gotten any response from them in quite a while. But, they did a lot of research and it was worthwhile. We're also seeing research on a thing called ionophoresis, which is using an electric current, two patches put onto the tissue, an electric current to draw the anesthetic through the tissue down to the nerve and anesthetize the nerve. It's been used a little bit in medicine. It is being worked on in dentistry, but I haven't seen a successful application yet. There's some research with light-activated local anesthetics. So I guess the bottom line is that although the injectables, needles are still by far and away the most reliable, we're still looking for better ways, easier ways, more comfortable ways to deliver the anesthetic, and that's encouraging.
Yeah, and that's always one of my questions. Like, anyone's guess is what the future looks like. What can we anticipate the future would look like or might look like 5 to 10 years from now with local anesthesia?
Well, I don't want to be a doomsayer, but I think we're still going to be using needles for a good while.
Yeah.
But I think that some of these patch delivery techniques, like the ionophoresis, some of the things that have been developed more for medicine and trying to adapt them for dentistry. Part of the problem with dentistry is that, versus putting a patch on the skin for anesthesia like you can do in medicine, we're dealing with a very moist environment, so a patch may not stick well onto the mucosa. We're usually trying to get deeper nerves, like the inferior alveolar nerve is rather deep through the tissue. Hard to direct the anesthetic that deep from a patch.
Right.
So, I think these things may have promise, but I think it's going to take quite a while to get developed.
Yeah.
And then getting the FDA approval to put them on the market is an extremely lengthy and we're talking tens of millions of dollars to get FDA approval.
Wow.
And so with new technologies, they don't come to market rapidly because of the time and money that's involved in developing them.
Yeah, and absolutely. And so a big theme that we always talk about is just always be learning. You can never learn enough in this whole process. And as we talk about how, technologies or even anesthesia has changed over time, patients have also changed. This is a different day and age in patients. And so we have Tom Viola on quite a bit, pharmacologist, and he's like, some of these things you see in a health history form, like the list is long. You really need to be on the front end of learning what patients are all about. So I'll reveal some of Tom's secrets, but Tom's really good. He's like, listen, when you see these things on there, when it comes to anesthesia, you just got to ask questions. What did you take? What are you taking? Did you take it today? And then do you know why you're taking it? And he says the answers these patients will give you will blow you away. And so while you don't need to be an expert on everything, would you agree, like we need to understand how these components all come together as patients change, right?
Oh, very much. Extremely important. The understanding the health history is so fundamental. And, we can never learn all these things, what all the potential drug interactions are. But there's some great references. I don't know if I'm allowed to mention a product, but I'll say Lexicomp is a great pharmacology reference source. It's designed for dentistry. You see that a patient's on a certain medication. You've never heard of this medication before. You can quickly look it up in Lexicomp, and it'll tell you exactly what interactions can occur with local anesthetics specifically, or with antibiotics, or with other medications that we use in dentistry. It's written specifically for dentistry. So you don't have to know everything. You just have to recognize and make sure that you're getting a thorough history from your patient. And then, like you said, Kirk, you're talking to your patient, asking questions. What do they know? Because some of these medications are being used for off-label use.
Mm-hmm.
And so you look up the drug and it tells you it's being used for XYZ. You ask your patient, do you have this disease? And they go, no.
Yeah, they don't.
Go, well, why are you taking this drug? Well, maybe they do know, maybe they don't know. And
right.
So sometimes you want to talk to the physician as well. So, I mean, it's interesting. It's a challenge.
Yeah.
And, it's the miracle of modern medicine that we see so many patients who are able to mobilize and walk into our dental offices. These are patients that 10, 15, 20 years ago were homebound.
Right.
It's made our world a lot more complicated, but I think it's kind of fun to have the challenge too. I mean,
100%. And
I don't want to be bored.
Absolutely. And go back to that, the challenge. So I'm 52. I've been doing this for 25 years. And when I first got involved, like the word preceptorship was a strong word. And I'll never forget, I was probably 28. And there's a great dentist. He was such a great guy. He's like, hey, everybody come over to my office on Friday. And so there's probably 4 or 5 dentists. He brought in lunch and he's like, listen, I'm going to teach you everything I've learned and done wrong in anesthesia. And a lot of it actually had nothing to do with the anesthesia. It was about communication. And I remember him talking about the pressure, like I always put my hand on the patient's shoulder and I do these things. I explain the pressure, and it was really calming just to listen to him. And I said, why are you doing this? He's like, I just don't want them to make the mistakes that I made, because this is one of those things that you got to get right. And I'll never forget the look in his face. He's like, anesthesia is one of the things you just kind of got to get it right. So let's go back to the title, Comfortably Numb. So let's say I'm a student of yours and I'd be the worst student, but like what would you coach me on, and how do I find comfortably numb, and how would you even define comfortably numb?
Well, so that's a great question. So first off, I mean, yes, you need to understand the anatomy, and, we talk about techniques, but you touched on something that's very near and dear to my heart, and that is talking to your patients. When I'm delivering local anesthesia to the patient, before I do it, I tell them what I'm going to do. Mm-hmm. And so, for example, I dry their cheek off and I put a Q-tip with some topical anesthetic on there, and I tell them, I'm putting a little topical anesthetic on here so you won't feel the stick of the needle as much. And then, I'm going to keep that Q-tip there, just a little bit of pressure. That helps so that you don't feel just the stick of the needle. And I'm going to do this really slowly. I'm going to tell you right up in front, I'm going to do this slowly so that it's more comfortable for you. And as I start to stick the needle in, I go, okay, you're going to feel a little needle stick here, but going to be real careful with this here. Right, here we go. I'm going to start pushing a little bit of anesthetic in. You're going to feel a little bit of light pressure. But I'm going to do this really slowly so you don't feel it as much. And, as I go along, I'm walking through and I'm talking to the patient as I'm doing it. And I'm telling them what to expect, what they're going to feel. And so, for example, if I'm going to shake the cheek, I tell them I'm going to shake the cheek, rather than staying, stoic and silent. And then I'm suddenly doing something, the patient's startled by, why is this guy shaking my cheek, or, these kind of things.
Right.
I want to avoid surprises. And the other thing, I'm trying to tell the patient what I'm doing and what to anticipate in terms of feeling and so forth. But I know that sometimes patients totally tune me out, and all they're hearing, Kirk, is this kind of blah, 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 in a calm, quiet voice.
Right.
But you know what? If that's kind of hypnotic to them, that's fine too.
Yeah.
It still works to relax them and remove some of that anxiety.
Yeah.
But the bottom line is that as I'm doing everything, I'm telling them what I'm doing to make this more comfortable for them. I'm telling them what I do to make this a better experience for them.
Right.
That to me is extremely important.
100%. And then do you ever feel like you're 100% sure they are comfortably numb? Or do you always live in a little bit of, I think we're pretty close? I mean, it's one of my questions. I'm curious.
I lived in that. Well, I think maybe they've got anesthesia, because how do we normally assess anesthesia? We ask the patient, do you feel numb? Yeah, my lip feels kind of numb. So you pick up an Explorer and you poke around, right?
Right.
Well, hopefully they don't feel that. And then you pick up your drill or your curette, whatever, and you get ready to go to work. And is it going through your mind, God, I hope they don't feel this. Last thing I want is for the patient to jump,
Yeah.
So I got tired of that. It's like, hey, no, this is killing me.
Yeah.
So simple thing to do. I squirt a little bit of endo ice on a Q-tip, put that on the center of the tooth. On the mandible, it'll be the most posterior tooth that I'm going to work on. If the patient doesn't feel that cold, you've got pulpal anesthesia. 99.9% sure they're not going to feel anything.
Yeah.
That's pretty darn good confidence.
That's really good confidence. That's a great tip right there. I love it.
Yeah.
Any other?
And you can do it. Same thing on the maxilla too. You can put it on whichever teeth you're going to work on, and it lets you know, so you're not hoping,
Right. Oh my gosh, I love this. I have like 90 more questions. Is that okay? And I got to ask,
fire
so
away.
I get all these questions. And so is it okay if I just dish them to you as being the expert? You know, one of the things that's important, every dentist learns this. There's only so much you can do, and then you just don't want to do everything. Your time is best spent doing only what you can do. Now, I don't know the number, but is there 44 states that allow others to administer anesthesia, or even more than that? I have no idea. So do you know?
There's for right now, there are 4 states. I think we're down to 4.
Down to 4.
It was 6. I think we're down to 4 now, where hygienists can give injections.
Okay.
Now, it does vary among states whether they can only give infiltrations, whether they can give infiltrations in blocks, whether they can do it without supervision from the dentist, or if the dentist has to be there watching them. There's all kinds of different rules from one state to another. But in most states, for example, I'm in California, and since I think it's 1972, hygienists have been able to give all injections in California. And I think it's made practice much more efficient. You know, the hygienist can anesthetize their patients as necessary. I can anesthetize my patients. Now, I do know some dentists who don't like giving injections, and so they have their hygienist give all the injections. And okay, that's fine. I don't think it's a very efficient way to practice, but if that makes you personally more comfortable, I get it. It's okay.
Right.
But does that kind of get at your question?
Yeah, I was going to get you're totally answered my question. And again, we don't have to be politically correct on this. You can say however you want. I actually have quite a few guests that are like, I don't care if anyone's listening to this.
Kirk.
I know, but I like being honest at least from your standpoint. And so a lot of people that I've had on here that are speakers are like, listen, I'll start this statement with, in my opinion, and so, and I do like the idea of others administering anesthesia. So I guess my question is like, what's your true feeling about others being, allowed or, able to administer anesthesia, and what are the complications? So I do have, and so that's my first question is, what are your thoughts about that? And then secondly, some people overthink this. They're like, no. I'm like, your state allows it. And they're like, no. And they still continue to burden themselves with all of the responsibility, which doesn't give them the time to really spend their energy on what's best. So that's kind of a 1-part question, 2-part thought process. What do you think?
Yeah. Okay. So, I think it's perfectly fine for auxiliaries to be able to give local anesthesia injections as long as they have been well trained.
Right.
And for example, in California, our dental hygienists are very well trained on administering local anesthesia. I have no hesitation whatsoever to let a well-trained hygienist give injections. And I think it's very beneficial to the practice. Now, for me personally, I prefer to give my local anesthesia injections because I feel that I can give them very comfortably, very successfully. And that right there tells the patient right from the very start that I am taking very good, very careful care of them. I think it gains me a lot of trust.
For sure.
Just in my mind, if you have the hygienist come in and give the anesthesia and the patient is successfully numb, and now somebody else comes in and now you do some other work, they're kind of going, well, how come that person did that and now you're doing this? It's, right. To me, I want to build a rapport with the patient where they know what I'm capable of. They know all the things I'm doing to make this a very good experience for them, and it starts from the first thing, from the injection on. Yeah. So that's where I'm coming from. But I don't think it's wrong for anybody to do it a way that they're more comfortable with. That's perfectly fine.
Right.
It's just personal choice.
Right. And if they're trained really well, this is an efficient process. It doesn't take forever to do this. And so give us an idea, like, how long does this process take you? I mean, I love that you said, like, getting to know the patient, asking. You'll find this if you're listening to this podcast. Get good at asking patients questions. That's number one. You can apply that to anything you do because you're going to get to learn. There's more intimacy. There's more trust that's created. But when it actually comes to the procedure itself, like typically, if I'm a dentist listening, what can I expect if I get really good at local anesthesia?
I'm going to answer that question, Kirk, but I'm going to digress for a moment here because you made me think of something here. So one thing I learned the hard way in my early years of practice is to, whenever I had a new patient, to talk to them about their prior dental office experiences, and also to specifically ask them about anesthesia. Have you ever had any problems, had any reactions, whatever, to local anesthesia? And, you get some really crazy, wild stories, of course, but a lot of it I found to really be helpful. And, I had a patient in my early years. He was a really nice guy, but I couldn't get him numb at the first appointment. Could not get him numb. So frustrating. And, I'm going, Ted, I'm sorry. I don't know why this isn't working today. I apologize. And Ted looks at me and goes, it's okay, doc. Every dentist has the same problem with me. And I'm sitting there going, what?
So instantly you're feeling better about yourself,
Well, more or less, but now I'm also feeling stupid because this guy is now telling me this story that it takes him 40 to 45 minutes to get numb every time. And I was too stupid to ask about that before I started working on him. And unfortunately, he didn't tell me. But now that I know, I ask patients these kind of questions before I ever start working on them. And it has made my life much easier.
That's a brilliant tip because you get an idea of what you're dealing with here. Yeah, absolutely.
Yeah. Instead of beating your head against the wall and, thinking that you're a jerk because you can't get this patient numb.
Right.
But I digress from your question, and I'm trying to remember what your question was.
No, typically just getting my brain around the time frame. When you really get good at local anesthesia, like what it takes after you've had many years of practice in this.
Yeah. So when I'm giving my injections, I palpate everything and I line everything up and I look, and then I come in with my Q-tip, a topical anesthetic, put it on the spot. I would say that my normal time for giving the injection, this is from start to, taking the needle out of the tissue, it's somewhere between 2 and 3 minutes. Mm-hmm. I inject slowly. And I'm talking to the patient while I'm doing it, like I said, and I take the needle out, and with my finger, I'm just massaging that area a little bit. And, Mrs. Jones, you did great. I'm really happy to see you're still breathing. I just kind of try to use a little humor here.
For sure.
It's dental humor, admittedly, but whatever. Right. And then I would say I should see signs of anesthesia coming on in 5 minutes. So I still ask the question, are you feeling some numbness? And if the patient says yes, that's good. And particularly with the mandible, if in 5 minutes they're feeling some anesthesia coming on, I will right then and there go and give a second cartridge of anesthesia at the same location. Because there's a lot of good evidence that shows that using 2 cartridges of our anesthetic, 2 of our 1.8, 1.7 cc cartridges, really gives a faster onset and gives more profound anesthesia to the patient. So in 5 minutes, if they've got signs of anesthesia, I know I was on target. I know I got the right spot. Let's strengthen it. If at 5 minutes the patient says, I'm not feeling any numbness, I missed, okay? So I'm going to reassess, repalpate. And do I want to go a little higher, a little lower, a little further back? Where do I want to go? And I will now come in and give the second injection at 5 minutes. That's not the way I was trained. I was trained you gave the injection and you waited 10 to 15 minutes to see whether it worked. And it's like, wow, man, that's a long time to sit there waiting.
It is.
So I'm trying to be more efficient.
Good work. So cool. Any last tips that you have or last thoughts you have on local anesthesia, or what would you tell? I mean, again, we have young dentists, like as they look at a career of 30 years of practicing or 20 years in front of them,
Okay, I'll toss out 2 tips here, Kirk.
Please.
Number 1, learn as many different techniques as you can. Again, the first technique we teach you is the traditional inferior alveolar regional nerve block technique. And that's the one that most dentists use to anesthetize one side of the mandible. But there's other techniques. I'm a huge fan of the Gow Gates. It's far more efficient. It has a higher success rate once you learn how to do it well. But you have to practice it to learn how to do it well. And again, there's another technique, the Vazirani Akinosi. You can also use infiltrations. There's different things that you can use, and you can use them in different combinations. So learn them. Don't be afraid to apply them where you feel that they're going to help you. And the more you use them, the better you get at them. So that's tip number 1. Let's see if I can remember what tip number 2 was.
Yeah,
that's the problem. You get me talking.
Hey,
my second tip here. I got it.
Go.
You called me an expert, Kirk, and I know you meant that kindly, but I go, no, I'm not an expert. I miss injections just like everybody. Well, hopefully not. Hopefully I have a good success rate, but I do miss injections. Let's leave it at that, okay?
Right.
And so the point is that I don't care how expert you are, you're never going to be perfect.
Right.
And you do still have a lot of anatomical variation out there. People are built differently. As a dentist, I wish they were all identical. It would make giving anesthesia easy, but that's not the way the human race is. And it's good because it would be a boring world if we were all identical.
Yeah.
So my point is, again, knowing different techniques allows you to accommodate all the different variances of human anatomy.
Yeah. I love your 2 tips because number 1, you can never, like I said, just learning as much as you possibly can, because you always pick up something from everybody. Like even if it's a verbal skill, it's so cool. And then I think your second point is spot on. And that's a big deal, is like perfect is just not a goal. Progress is a good goal.
Can I add one more thing here?
You
Kirk?
can add as many as you want.
One of the things I really love about teaching is it makes me, stay on top of things. Yes, true.
Yeah.
But I love the questions that students or people that attend my CE course, I love the questions that they ask, because it makes me think about things a little differently or a little different situation. It helps me to learn, to think about these problems that they had and trying to solve their problems. So, to me, that's, again, this constant learning. It's not just me spewing out my fountain of expertise. It's, hey, I love what you guys ask and the problems you bring me, because I'm learning from it too.
Yeah, I love that. And I personally believe that teachers and military, those 2 are the heroes of this world. And so I'm always curious, and this is a little bit off topic, but the teaching aspect of things in dental school, like what are some of your favorite things, as because I know there's a lot of dental students listening, and what are some of the advice that you'd give them? Because I talk to these kids and they're like, yeah, I got to get through this. And I'm like, you're going to be fine once you get out there. Like, what are your favorite things that you say to your students or see in your students?
Well, so, there's so much to learn. Mm-hmm. And there's no way you can learn it all, remember it all. I think, unfortunately, our students come from college and our education up through college. Students are largely memorizing information and then just spewing it back out for an exam. Dentistry is that's not going to work. You need to actually learn things. And so it takes learning those facts and figuring out how do they apply, how do they integrate together, how do they work together, understanding why we do certain things the way we do. If you're doing a resin filling, why are the steps laid out this way? What are we trying to accomplish at each step? And what goes wrong if we don't do it that way?
Right.
That's how you really integrate that knowledge. And then it becomes intuitive, and you can extrapolate from that and adapt to different situations. But, you're going to make mistakes. We all do. Try not to make big ones. Try not to make dangerous or costly ones. But pay attention. Learn from your mistakes. Don't be afraid to make a mistake, but don't be stupid enough to not learn from your mistake.
Yeah. I think that's one of the best lessons ever is just take a deep breath and go, this is bad. Okay. When it does happen,
a question, give me an answer.
Right.
If it's wrong, that's okay. At least you're thinking and trying.
100%. 100%. Well, Alan, I've absolutely enjoyed this, and I really appreciate it. Now, if I'm listening, how do I find out more about what you do, or how do I reach out to you if I have a couple questions? How do I get a hold of you?
Best way is email. My email address is Budenz. So A is my first initial, Budenz is my last name. So Budenz at Pacific, Pacific, as in Pacific Ocean, .edu.
That's awesome.
So Budenz at pacific.edu. I'm always happy to answer questions, always happy to help. If you want to talk on the phone, we can set up an appointment by email and we'll make it happen.
Sounds good. And I prefer a visit personally because that's one of my favorite cities ever. I just love it.
Oh, great. Yeah.
Oh, it's just amazing.
Always welcome.
Yeah. So, Alan, thanks for being on. I really appreciate it. Stick around for just a second while we say goodbye to everybody else. But
my pleasure. Thank you, Kirk.
Oh my gosh, it's so fun. So thank you guys for listening to the Best Practice Show podcast. I hope you enjoyed today. Remember, this is a big piece of dentistry. This is a big piece of understanding your patients. And so I hope this was helpful to you. If you enjoyed today, do us a favor, just share this with your friends. Keep sending us suggestions for things that you guys want to see. You're going to see we have an amazing summer lined up. And until we see you guys next time, keep watching the Best Practices Show. You guys enjoy your day.